Hello, my name is Dr. Peter Carr, and I'm here to present the Myovision, what I like to call my secret weapon in personal injury cases for documenting soft tissue injuries. I was exposed to Myovision about 10 years ago when I met David Marcarian, who was a NASA researcher, when he was visiting Palmer College of Chiropractic in Davenport, Iowa. We just happened to meet, and he talked to me about what he was working on. And his product, the Myovision, works off what we call surface electromyography. And surface electromyography, as you can read on the slide, measures tiny impulses from your muscles when they generate electricity as they contract. An EKG does this for the heart, but the Myovision does it on a more sensitive level on the surface of the skin. We can measure actually down to the 1/1,000,000th volt levels. And so this is a really easily reproducible graph that we can chart over time. So the EKG really started off electricity and measuring it in the body. And so when we look at the heart, we're measuring something deeper with depolarizations. But with the muscles in the neck, what we're looking for is a constancy that we can find. So we have some kind of reproducible measure of what muscles are doing at any given moment. So it's really easy to measure the guarding because we can see it on a graph as it goes. EMG stands for electromyograph. Electro means electricity, myo means muscle, and graph obviously means that you're writing it down. There's really two different kinds of EMG. There's static, which is where we're measuring somebody in a neutral posture, where they're standing in one location, and then dynamic, which is what the Myovision Dynarom does. And that measures it with a range of motion at the same time, charting it real time as we go through. It's really exciting for chiropractors and for people who are working in whiplash injury because it shows the muscle activity as someone's going through the normal ranges of motion and documents that very, very well. We'll show you that here through this presentation. On the left side of this slide, you'll see the static or paraspinal surface EMG. On the right, you'll see the Dynarom. You can see the definite differences. One is from a snapshot moment in time along the spine showing muscle activity side to side. We often use this as a screening tool. Its validity is still there, but it's certainly been questioned in the literature, probably because it's been used in different ways for different products. The Myovision actually does accomplish this activity, and it's good to screen it. But what I really want to talk to you about is the Dynarom motion surface EMG on the right hand side. And I'm just going to stick to the lumbar spine today because we've got this for the cervical spine as well for the neck, which is probably more relatable in the whiplash field. But I want to make sure that it's really simple and easy for you to see how the Dynarom works, then you can apply it to the cervical spine as well. So on this right side you can see here we've got a picture of someone bending forward and bending back up again. And as they bend forward, we'd like to see this range of motion go through as we do. So we'll chart this progress as we go. We'll show you how it works and why it's important on the next slide.
E1.
So you can see this picture here on the left. This is actually David Marcarian right here, and his
L4.
and his partner here. He's doing these individual screens at different levels of the spine, and it generates this picture on the right-hand side. The one that I really want to talk to you about is not the static EMG, which is just one location.
Release button. Begin scanning.
But this one, where it's the Dynarom SEMG. And this one, where you can see the pad here on this person's hip, this is a 3G transmitter, and it goes into electrodes on the spine. And on the back, you will see this again too, are two range of motion meters. The graphs here on the top and bottom, the one on the bottom measures range of motion, and the top measures the activity of the muscles in the two electrodes from the machine. Chiropractors and attorneys both like the Dynarom evaluations because it really is a lie detector for low back pain and for neck pain and for people who might be faking, of course. We like it because there's no way to fake the tests. We've tried every direction we can. I've tried every person that I can, normal healthy responders, even telling them how it works and what to do, and they just can't do it. So it's a really great way for attorneys to see if they have a good case up front. If they have a soft tissue injury, sometimes that's the hardest thing to defend because there isn't any objective findings to present to a jury. And so I've even talked to attorneys who won't take cases based off of that. So this changes that for us. It's really exciting. So here's how the two tests work in the low back. We have people bend from side to side and forward and back. You can see what a normal person looks like here. You can see that if they have simultaneous muscle firing on both sides, that means both muscles are firing at the same time. We know that there's guarding in the spine and that injury has occurred. So this one is, you can see the clear difference between the two peaks here. These tend to run together in a very relatable fashion, and this one is disjointed, and you can see the fasciculation going on in the meantime where this is moving up and down. So not only can we document injury, but we can also document how long the person's had it. So this picture right here shows the whole Dynarom equipment. You can see the two range of motion meters here and the transmitter here. This is what a normal bending forward and bending back looks like when someone bends forward. The normal spine motion is that when you get into a fully flexed state, the spinal muscles relax. And we can see that here as this person bends forward. You can see what we call a quiescent period here. And then as it tilts back up, you're activating the muscles to bring yourself back up again. That corresponds to the range of motion change, and that person's vertical at the top. So this person, you can see at the end here, the acute problem, you can see how this is up and down and up and down and up and down. The range of motion here, well, at least on this person, is consistent throughout that range, but you can see how the muscle activity is concomitant on either side, and it's firing when it should be at rest. And you can see the same thing here. So it's really documentable on this case, where we can say for sure one person is or one person is not screening out as a normal. So this is where it brings up the question of range of motion, which is what I've been using for a decade in my clinic. And this is normal range of motion. I have a range of motion meter in my office. I've been using it for many times, and when I have someone reach this normal range of motion, well, they were gone. So that's what we've been doing for a decade. The same person evaluated with the range of motion and the Dynarom meter. When you look at this, you can show the two pieces together so that this person may have normal range of motion, but the muscle activity that we can't see, with chiropractor may be able to palpate and feel, that's not working the way it's supposed to. If it's not shut off when someone's in flexion, that person has been damaged. It's just a matter of chronicity by that time. So it really does give us a quality of motion in relation to the endpoint that you can see. So it provides us another way to look at the human body. We have MRIs that show that the person doesn't have damage or any kind of space-occupying lesion. Or in flexion extension films, we find that the ligament laxity isn't there, and we find movement on the bones. The Dynarom motion really does establish that change for us, and so when we see an abnormal Dynarom, we know that the muscles are damaged, and I'll show you how solid the literature is to back this up. We've had a number of cases that have settled for hundreds of thousands of dollars. So the AMA guides, which are really the standard for what we measure on patients, recognizes the Dynarom SEMG. They also recognize that muscle guarding and spasms have a 5 to 8% impairment without objective verifications with electrodiagnostic findings. There is no comment as to what it is with those electrodiagnostic findings, only that we know that it's more than 5 to 8%. So when we look at the Dynarom and someone who knows the difference between these, an attorney especially who knows the static and dynamic EMGs, we can dispute the findings for one to the other when we get into court. The insurers will want you to only focus on static EMG, and that's what they've been fighting for years and years. But the problem is that we have these patients now who have back pain, can't get it diagnosed properly, and then they have to reflect that back to their insurance company, to their family, to their friends. They're skeptics, people who believe that they aren't hurt, but they actually are. This really does separate the wheat from the chaff when we get into this. So what I'd like to do is address some of the naysayers and downsides of what the SEMG is about. These are a lot of the different kind of findings that I've had with insurance companies and with attorneys saying it doesn't work, but each one of these can be addressed very, very easily, and it's exciting for me as a chiropractor because I finally do have a tool, a defendable tool, to finally explain exactly what it is that chiropractic works on. So you can see these are here listed. I won't read them all to you, but I'll kind of go one by one as we go through. Essentially, they're always going to hit the validity, the reliability, the admissibility, and the recognition of the test in the general community. And that's really what I want to talk about with you today, is that when you send someone to our office for a Myovision evaluation, this is all in the background. It's going on without you having to think about. The first one they're going to hit you with is that there are no studies to evaluate and validate SEMG. This is a test that a PubMed evaluation that I did just yesterday. You can see there's over 8,500 studies on surface EMG alone. This is a really hot area in research right now, and even in the last 2 months I've seen this number go up by 200 studies. So it's really easy to go in here and say absolutely does it have validity, and there's at least 500 or 600 good studies that we can use to back up the surface EMG. They also want to hit how it doesn't relate to whiplash, but there's a number of issues of spine that have shown this, where we show that the cervical spine has been damaged in whiplash, and you can see how they assess it using, there you see it, surface electromyography of the upper traps, which is something that we use for the Dynarom as well. They'll also hit us with the idea that needle EMG is the only kind of EMG. Now, if you're not familiar with EMG, this is where they do a test where they shove a needle into your muscle, and they have that muscle go through a range of motion, and they listen to the noise coming from that muscle. And you can see that here on these two pictures, where this person's bending forward, and as they bend forward, we see them activate shortly, and then they're quiescent when they're down at the bottom, and then as they come back up, you hear this noise again coming up. So the neat thing about the Dynarom is that it is a summative process. Because we're putting it on the skin, it's measuring it from a much larger area. It's kind of like looking at a full TV screen versus a pixel or two to try to determine whether the picture is working or not. And so the lines here on the bottom is something that the Dynarom would put out. This on the top with all the noise here on the right is, again, what we would see if we summated those. So in many respects, the Dynarom is actually a better way to look at this than the EMG, and it's really self-explanatory when it's put in those terms. I love it when they hit with the poor reliability issues. We have a number of studies, and you can see that they have p-values here of 0.001. Anything 0.05 and above is pretty well given that, yeah, there's really good correlation to that. Obviously, this is a hell of a lot better than that. And again, we can back you up with these. They often say that they haven't used the control group studies using the Myovision. This is a study on chronic low back pain, and they talk about what chronic low back pain costs per year. You can see $50 billion a year is what the estimate is. And they show how surface electromyographic studies can demonstrate whether someone is experiencing chronic low back pain. Really is a lie detector for us. Again, you can see here this is a p-value of 0.00001. That's pretty much saying that's the deal. The instant credibility is a really good thing for us to look at, because we talk about how the Myovision is actually used in a lot of these research studies. And in my clinic, the Myovision is really the standard now for surface EMG, especially in the chiropractic and medical fields. And I'll show you exactly how involved that is. But many of these studies use that Myovision because it's the simplest and easiest way to make sure that we can evaluate the muscle activity. When they say that the test isn't supported in courts, this is a test from, or a summation from David Marcarian versus 300 insurers down in Florida. It was really just him as an expert witness, and the state of Florida actually dictated that SEMG does have level of medical acceptance as a valuable diagnostic tool there, and so it's actually required to be paid under the state statutes. And so this is really breakthrough watershed case, because it's a precedent for other cases as well in other states. And I'll show you why and how that happened here, more from a legal standpoint. Although I'm not an attorney, I do have a lot of dealings with these. So this is from a Superior Court case here in Washington. that shows that yes, in fact, the dynamic EMG has been used here in the state of Washington. In the court, it has a 100% win rate when it goes into a court case, because it really just is indisputable. And it's amazing to me how many personal injury attorneys who say they specialize in that don't use the Myovision or refer out for it. It's a very easy, straightforward test to not only see if someone's been damaged, but whether they're making progress and whether they should be released from care for that injury. This is an IME that we essentially destroyed here. He said up here, there's no validity to this testing and has no merit to be used in evaluating any individual. The cost for $300 should not be included. But I think that going to, you can email David. I put his email on there. He'll send you the email, and you can read how it's just devastating. I don't think they'll ever ask this guy to ever testify again. It's just embarrassing. So it's pretty funny. So it always comes down to data when you get to this. When I start to deal with IMEs who say that it's not valid, and yet I have a Dynarom SEMG that shows that it is valid, it's really black and white. It's like an X-ray for the spine, or when dentists use that dye in your mouth. It shows where the plaque is. This shows where the damage is. It's been admissible in court, obviously, and it also has been approved by the Quality Assurance Commission here in Washington as a diagnostic device. And so when we look at that diagnostic device, it has to have a CPT code attached to it. And the CPT code you can read here is the current procedural terminology. Essentially, when you go to the doctor's office, if they give you a Band-Aid, or if they do a surgical procedure on you, every procedure that they do has a 5 or 6 digit code now, and that coding is something that's attached to a bill. And the neat thing about that is that the CPT codes are managed by the AMA, and they won't allow a CPT code that is not valid. And so you can see here the codes for the Dynarom are the 96002, dynamic surface electromyography. We can also do a review of that, so there's a professional component and a diagnostic component as well. We can separate those out if we'd like to. This young man, John J. Gerhardt, he essentially is the father of the range of motion assessment in the AMA. These are the AMA guidelines. It's actually page 47 on the guidelines. You can see here as an example the Dynarom device in the AMA guidelines. It's really tough to not agree with it when it's in their own guidelines. Courts are now aware of this too, so they're starting to catch on that static and Dynarom EMGs are different fish. One is measuring the actual what's going on at the time during the range of motion. The other one's during a postural evaluation. So they're starting to catch on to this. It's easy to settle for a case for a larger value. You can read about one down here with Dr. Fraley. He is my counterpart out in Spokane. The evidence having the Dynarom there versus the Dynarom not there is essentially relying on what they're feeling versus what they're seeing. And so the hard data always wins. I always tell my attorneys that essentially when I tell them I've got this Dynarom, it's like bringing a knife to a gunfight. Maybe I shouldn't use that out loud. But you can see the left, you can see the right, how this is different. It gives you a good idea of what you're looking for and why attorneys now call this the lie detector test. You don't have to bother cutting my bills anymore because it's a defensible product. You have cases that settle fast, and they settle for more than you'd ever want to because now we have some data to rule out the soft tissue injuries. We can screen out the fakers. It's a really great way for you to send patients off right as you get them through the door to see if it's a case you even want to take. Now, this is a shameless plug for my office. DCC is the clinic that I run, and I've been there again for 14-15 years. We run off the Croft guidelines for treatment in my office. We do use the Myovision on site. We have certified doctors that work there, and we also use massage therapy as well. We also are functioning with dynamic stabilization rehab for the spine on site, which uses balance and lasers, and it's really fun to look at, and it's really great for patients. We also have on-site x-rays that we do for flexion extension films, We have everything that we need to take a case from start to finish. Our notes are also pretty tight. So this is the end of my presentation. If you have questions, I would love it if you would send me an email. My email is dr.carr@dynamicclinic.com, and I'm more than happy to do this presentation wherever you would like. This is my first recording, so I'm going to go ahead and hang up now and see how this worked, and we'll go forward from there. Thank you very much. Have a good